EMOG Eastern Mediterranean Oncology Group, and it is our honor to start today meeting about the art of neoadjuvant therapy in breast cancer. We have a great faculty with us. We will, with our moderators, Professor Mohammed Shenawi. He is the Vice President of University and a Professor of Surgery at Ain Shams University. He is one of the pioneers in breast cancer surgery and breast cancer research with a lot of publications. And Professor Ahmed Abdelhadi is Professor of Clinical Oncology at Mansoura University. Let me start with the first speaker, Professor Rola Shaheen. Professor Rola Shaheen is a consultant radiology at Peter Pro Medical Center at Ontario, Canada. Professor Rola is a lot of experience in the breast imaging and breast intervention, and it is our honor to introduce her with the first talk, inshallah. She will talk about the journey of breast imaging during the neoadjuvant therapy. Please, Dr. Rola, you can start. Dr. Rola, please unmute the mic.
Yes. Sure, that's the most important thing in 2020. You are on mute. Okay, so thank you very much for the kind introduction. I'm very pleased to be at this intellectual meeting, and I'll be talking about multimodality breast imaging utility in breast cancer therapeutic journey. And the objectives of my talk are the following: to clarify the role of multimodality breast imaging in screening, diagnosis, management of breast cancer, with a preview on when to scan the axilla, and highlight the role of breast imaging in monitoring neoadjuvant therapy, discuss emerging technologies such as contrast-enhanced mammography, and illustrate cases with pearls and pitfalls as we go through the presentation. As we all know, breast cancer is the most common type of cancer and the most common cause of cancer-related mortality. And the global burden of this cancer is substantial. However, the burden is not evenly distributed, with variable outcomes of breast cancer based on geography. Let's look at the breast cancer journey through the lens of prevention, screening, diagnosis, treatment, survivorship, and end-of-life care. However, for the scope of my talk today, I'll focus on the screening, diagnosis, and treatment, because as we know, we can't prevent breast cancer. It's very important to focus on early detection, which is through screening, and timely diagnosis, which are the keys for best outcomes. Due to screening and improved therapeutics, we have seen decreased breast cancer mortality rates in the past 20 years almost, or even I would say 30 years. It's important to consider breast cancer as a heterogeneous disease with multiple different pathologic subtypes. Therefore, there will be different therapeutic paradigms. This is very important when approaching breast cancer treatment and understanding how its outcome will prevail. Starting with screening mammography, as we know, it's the cornerstone for early detection of breast cancer. And as I said earlier, the decline in breast cancer mortality since 1990 is mainly due to the early detection through screening and improved therapy. However, we are all aware of the limitations and challenges coming with screening mammography due to breast density, the fragmented screening programs, variability of quality of the programs with limited access to resources, and other barriers such as the international barrier of fear and the confusing guidelines for our patients. Let's start to unpack basically the challenges. So as we know, breast density is a risk factor. As you can see here to the right of the screen, this patient is with extremely dense breast and obscured cancer somewhere. However, the patient on the left, you can see here, it is basically you can easily spot the small cancer, which is few millimeters, because the patient has scattered fibroglandular densities. But despite that, despite the limitations of mammography in dense breast, it's still very useful to have a mammogram for this type of woman, because you can still detect the suspicious clustered microcalcifications, and the architectural distortion. And I'll show you a couple of examples for that. This is a patient who was called back from screening mammogram in 2019, because as you can see, compared to previous in 2010, there was a new faint cluster of microcalcifications with the MAG view. Here you can see it there. We have seen 2 clusters of microcalcifications. One of them was suspicious, ended up with a stereotactic core biopsy, and the patient actually had DCIS. And on MRI, the extent of disease was much more than what anticipated on the mammogram. So this patient, as you can see here, there's area of enhancement in the outer breast, and ended up with right mastectomy in February 2020, and she's awaiting reconstructive surgery. So without the screening mammograms, we wouldn't have known that this patient had that large extent of cancer. Another example here, this is a young woman, 40-year-old, lactating for 14 months with a palpable lump. As we know, lactating breasts are very hyperdense on screening mammogram, yet when a patient has a lump during pregnancy or lactation, we still work them up with mammograms at the right age. You can see here at the BB, there is an obscured mass. With spot compression views, you can see that there's a speculated mass with some calcifications. Patient was taken to ultrasound, and on ultrasound, obviously you can see the irregular hypoechoic solid mass with echogenic foci, internal vascularity. This patient ended up with an ultrasound-guided core biopsy that showed high-grade invasive ductal carcinoma and DCIS. Patient underwent lumpectomy, chemotherapy, and radiotherapy. Now, yes, the dense breast can be a nightmare with screening mammograms. However, there are emerging technologies that are going to help us actually have more confidence in telling the patient that they don't have cancer. This is a recent example for contrast-enhanced mammography for one of our patients, where you can see it's extremely dense on the regular 2D mammogram. However, with contrast-enhanced mammography, it's a pristine, quiet breast, and we were more confident telling the patient that there are no suspicious findings. So it might be the answer. Also, when we talked about the challenges, we entertained the fact that there are fragmented screening efforts, and it's very important to join them all under one umbrella for the organized cancer screening programs to reduce the impact of breast cancer. So we will need national and organized breast cancer screening program with an overarching integrated mammography quality management program, and have that program actually target overcoming the barriers for screening mammography and access to diagnostic assessment. So this would start by awareness, as we know, which a lot of Middle Eastern programs are working very hard on that, so that women would have access for better care. We're lucky in Ontario, where we have Ontario Breast Screening Program, which basically actually addresses 2 things: the women at average risk and women at high risk. Also, we do have a quality management program that started a couple of years ago, and now it has been with OBSP. And with that, basically, this report is very important so that the health workers know how's the performance, all the way from the key indicators to the centers and facilities performance, even at the radiologist level. And they would benchmark that with the previous years so that you can see if there is an improvement or not, and what are the areas that need to be worked upon in terms of quality improvement. The other challenges, as I said, was the fact that there are confusing guidelines in the media about the role of screening mammography. And again, this is not the scope of discussions for this talk, but I really wanted to highlight the importance of being aware of the role of screening mammography. And if my patients are asking me, I would always say, yes, it does save lives, and it's important to get your screening mammogram. Now, moving to diagnostic workup and interventions with image guidance. As we know, breast cancer is diagnosed either by a patient coming back from screening mammography, or the patient is presenting with a clinical symptom. And sometimes the patient would have a radiology study for something else, just such as a CT chest that would detect breast mass or axillary mass, or even a bone scan that detects a metastasis. Unfortunately, more than 50% of breast cancer patients have clinical symptoms at the time of their diagnosis. Therefore, Timely and accurate diagnostic workup with image-guided biopsies are crucial for early detection of breast cancer. So these are some of the late signs and symptoms that patients present with, and these are actually most of them my patients from the Middle East, where awareness was very much needed, such as nipple inversion and inflammatory breast cancer, as you can see here, a palpable lump in a neglected elderly, and unusual decrease in size of the breast because basically the tumor has fibrosis. So the multimodality breast imaging and image-guided biopsies would include the following. That would be diagnostic mammography, including spot compression views, magnification views, sometimes even rolled views for the asymmetries and architectural distortion with targeted ultrasound, and breast MRI when there is problem solving or preoperative staging. This is important to assess for the extent of disease because it's very important for the surgeon and the oncologist to know if the disease is multifocal and multicentral, whether the muscle and wall are invaded or not. Also, it's important to screen the contralateral breast to rule out cancer, assess the axilla. And the biopsies can be done under image guidance with ultrasound, under ultrasound guidance, which is the most common and most convenient for the patient. Stereotactic biopsy, which is, as you know, it's done under mammography compression and MRI-guided core biopsy. Just to share our experience in one of our breast clinics here at PRHC, we have done in 2019 386 patients under ultrasound guidance, and I just wanted to highlight the fact that almost 60% of those patients came with symptoms, yet 41% were positive for cancer from screening, like they were diagnosed based on callback from screening, which is really a good percentage. Unfortunately, during COVID, we did have to pause the screening services for a few months, and as you can see, the percentage in 2020 has dropped by 5%. As for our stereotactic core biopsies, also the numbers have dropped in terms of the number of biopsies because of the limited access to services during the pandemic. Yet what was interesting, the positivity has gone up, mainly because of the fact that we, in terms of our planning, we gave the prioritization or the priority for the patients who have highly suspicious calcifications. Let's touch on one of the cases that came to us for stereotactic core biopsy and learn some of the pitfalls in our workflow. A 77-year-old woman presented to our department for stereotactic biopsy with a cluster of microcalcifications that was marked as BI-RAD4A. And as you can see here, it's almost punctate, rounded. It's true that's BI-RAD4A. However, as radiologists, we are responsible for the patient as a whole and the breast as one organ. So it's important for us to go back and check the bilateral diagnostic mammograms and to check the history of the patient. So we noted that the patient had a palpable lump at her initial presentation, which as an ultrasound was done for her, and it was thought to be due to fat necrosis, and follow-up was recommended for that area. So let's look at the diagnostic mammogram together. And here is the triangle marking the area of palpable lump in the left central breast. And you can see that there is an asymmetry. We did a spot compression view on it, and it's not completely pliable. It's still there. Probably there's a mass. The patient was at that time taken to ultrasound, and there was, sure enough, there was a mass. It looked mainly echogenic. However, if you look at the setting of the ultrasound for the radiologist in the audience, you can see that the focal zone actually is pushed down away from the mass, and it's focusing on the pectoralis muscle as opposed to the mass. So we took the patient back to for a second look ultrasound, and we put the focal zone higher at the mass itself, and sure enough, you can see that there is a heterogeneous mass with posterior acoustic, which is very suspicious. At that time, we decided to go ahead and do the biopsy. We left post-biopsy clip, and that was an invasive ductal carcinoma. So it's very important for the radiologist to go back and look at the whole picture rather than just following what's in the requisition. This is another patient where in 2017, she was called back from screening mammogram. There was a nodule in the upper central posterior depth of the breast. Spot compression views showed the mass, and we do true lateral of the nodule. Targeted ultrasound was performed and confirmed the solid nodule, and the biopsy performed and showed invasive carcinoma. Why am I showing this case? Because I I really want to stress the fact that patients with posterior nodules, very important for them to get MRI preoperative, regardless of the density of the breast, to make sure that there is free margin between the mass, the cancer, and the chest wall or the pectoralis muscle. And in this case, it was free, and the patient got to have lumpectomy, and wire localization was done under mammography guidance for the clip. Here's another patient with almost entirely fatty breast. However, there is some increased density behind the mass concerning for pec muscle. So in this case, if you do an MRI, it was debatable. It depends on the surgeon. Another case, a patient who was 63-year-old presenting with a new mass in the posterior depth of the breast. She had lumpectomy before that in 2017. And here are some tomosynthesis confirming that the posterior mass is actually invading into the chest wall. Yet on ultrasound, it wasn't very clear. And the ultrasound guidance shows that this patient had recurrence. And here is the CT scan of the chest showing the speculated mass extending into the chest wall on both the axial and the sagittal views, and the MRI with the contrast enhancement confirmed extension of the enhancement into the posterior wall, into the anterior chest wall of the chest. So let's discuss the role of the MRI. This is the case showing actually architectural distortion in the upper outer breast. On spot compression views, it's actually more obvious, and targeted ultrasound showed vague hypoechoic mass that was biopsied, turned out to be invasive ductal carcinoma. On MRI, you can see the primary cancer with the flow void signal from the post-biopsy clip. And the second mass was also noted in a completely different quadrant. We did the second look ultrasound, however, we couldn't see that mass. Therefore, the patient ended up with MRI-guided core biopsy, turned out to be DCIS. So in a way, this is a multicentral disease, which took the patient from the opportunity to have lumpectomy to mastectomy based on the MRI findings. This is a young patient who is 38-year-old. She was pregnant, presented with a lump, but also, as you can see here, she has saline implant. And yet, even with the implant views, you can see a speculated mass, maybe some other nodules noted around, probably there. On spot compression views confirmed that she had the ultrasound and the biopsy was done, and it was cancer, invasive ductal carcinoma. The MRI actually showed us the extent of the disease, where you can see the main mass indenting the implant itself. Also, there's nodular enhancement around the implant, as well as enhancement of the nodule superiorly. So basically, this is a multicentral disease, and mastectomy was basically the way to go. Another useful thing about the breast MRI, even after surgery, when the patient has positive margin, it's very helpful to assess if there is any residual disease. As you can see here, here's the hematoma or the seroma from in the surgical bed. Yet you can see abnormal enhancement in the posterior aspect, which basically tells us that there is residual cancer in there. I would like to talk a little bit about scanning the axilla and how's the new approach now to this, because basically we need to balance the common practice of automatically scanning the axilla in the setting of suspected breast cancer, because we were trained as radiologists. Whenever we see a suspicious mass, our reflex is to go and check the axilla and see if there is an increase in size of the cortex thickness. However, this needs to be balanced with a couple of things. The risk of overstaging, which results in overtreatment with chemotherapy and axillary surgery, and draining on resources without clinical benefits, and limited clinical utility of identifying the low volume axillary burden. As we know, lymphedema is no joke, and a lot of women actually suffer from that. Because of the sentinel lymph node biopsy is part of the primary surgical management for low volume axillary disease, based on the clinical assessment, really, we have put together in agreement with our multidisciplinary team that we don't routinely need to scan the axilla. And the protocol will include the following. So in terms of scanning the axilla, if the tumor size at the time of the evaluation was 2 centimeters or larger, if there is suspected inflammatory breast cancer or multicentral or multifocal disease, also at the radiologist's discretion to help the radiologist have overall interpretation. For example, if I see a mass that looks like a fibroadenoma, however, I'm suspicious, sometimes checking the axilla can make me more confident, like if there is high thickness or increased thickness of the lymph node, that would make me more suspicious that this needs to be biopsied, as opposed to negative axilla. Or of course, we scan the axilla whenever we get an order by the surgeon following clinical assessment. So what would the radiologist need to do? They need to report the number and the number of the suspicious lymph nodes and their level. They can go ahead and biopsy if the cortical thickness is more than 4 millimeters. Also now with the Z11 study, and again, this is beyond the discussion of this talk, we go ahead and do the biopsy and put a clip in the lymph node whenever the suspicion is BI-RADS 4C or 5, like highly suspicious or highly suggestive of malignancy. And the clip can also be ordered by the surgeon even after the biopsy results, which is challenging because sometimes it's very hard to know which lymph node has been biopsied. And I do recommend trying to use a clip that you can see under ultrasound because basically that would be the way to localize the lymph node after it after the cortical thickness dissolves. And it's best to use something that can be visible under ultrasound, for example, using the hydromark, because it would look like fluid collection. Now, let's go to monitoring the neoadjuvant therapy. So by definition, if the treatment is being administered to the breast cancer woman before surgery, it is neoadjuvant. And the therapy is available, as we know, either local regional therapies such as surgery and radiation, and the adjuvant therapy can be chemotherapy or endocrine therapy, which my colleagues are going to discuss. But the essentials for imaging of neoadjuvant therapy response are the following. We need to work up the bilateral breast and the whole body imaging to know the stage of the disease. And when we do the follow-up to assess for the response of the treatment, we have to use the same imaging modalities so that we can compare apple to apple. It's very important to consider contrast-enhanced breast MRI whenever it's available, because it does have the highest accurate diagnostic assessment for the primary tumor, especially with its vascular and kinetics capabilities. And when you combine that with clinical examination, mammography, and ultrasound, we will get the best results. Because of the limitations of the conventional methods, and these are the physical examination, we know that the accuracy is only 57%, which is low compared to mammography, that is 74% and ultrasound is 79%. Also, limitations can be due to, clinically, due to the overestimation of the size of the tumor, either before introducing the treatment because post-biopsy complications happen, such as hematoma, or even after treatment, sometimes you can overestimate the size of the tumor due to the fibrosis and the firm fibroglandular tissue. And keep in mind that interval loss of the palpability after treatment does not rule out the residual tumor, because still imaging is essential to see the non-palpable findings. This is an example for a patient who had a stereotactic core biopsy, ended up with a large hematoma that would give a false impression that the tumor is large enough, and this was the aspirated hematoma. So again, the highest predictive value for predicting pathologic response for neoadjuvant therapy would be using breast MRI and clinical measurements for the tumor size. And using body imaging is very important for staging, depending on the stage, and depending, again, access to imaging modalities and the guidelines within the country that you live in. So in North America, mostly they would use PET scan. However, in Ontario, we don't actually have that kind of recommendation because we don't have access to a lot of PET scans facilities to do a workup for breast cancer patients. So we end up doing a lot of CTs, such as abdopelvis and chest and head. And sometimes also, obviously, we will have to do bone scan. And this all happens in discussion through multidisciplinary care. So multidisciplinary approach is the way to go. This is an example of a bone scan. abdopelvis scan, coronal views, axial image through the head. And actually for the head, to rule out metastasis, we prefer MRI when possible, if there is access to it. And here's the chest axial image on bone windows. Speaking of MRI and doing the pre-therapeutic MRI for staging is important. This young woman in her 30s had the cancer, as you can see here, with suspicious kinetics and metastatic lymph node. And here's a sagittal view. You can see the extent of the cancer, and after treatment, after the chemotherapy, actually it all dissolved, which made even the surgery much easier. They just went for the clip side, the post-biopsy clip, and the patient ended up with small lumpectomy. Another case here, this is actually a recent case, an unfortunate 50-year-old woman presented with diffuse hardening in her left breast in September 2020. She had previous left breast cancer treated with lumpectomy in 2017, and as you can see here, there are multiple asymmetries. And on targeted ultrasound at 2 o'clock at the area of main palpable mass, you can see a solid hypoechoic mass with posterior acoustic shadowing. And this was biopsied and turned out to be invasive ductal carcinoma with ER, PR, and HER2 positive. But on further scanning, there were numerous abnormal hypoechoic nodules throughout the breast. Like the sonographer went to number 16 and 17. So it was all over the breast, and that was inoperable. And the patient ended up starting on neoadjuvant therapy in September. And in December, we did a follow-up ultrasound, and she has very good response, actually. If you can see here, the 2 o'clock largest mass actually ended up to be going down from 4 centimeters to almost 1 centimeter. And the other nodules throughout the breast have did shrink and get smaller in size. They didn't completely dissolve, but there is some residual nodules there. But she had very good response to chemotherapy. So just to put it together in terms of the summary for neoadjuvant therapy, the ultimate role for the breast imaging in neoadjuvant therapy is basically to evaluate the therapy response by determining the presence of the size and of the residual disease, which is important for preoperative planning. And currently there is still lack of consensus on how to best assess the response to treatment. So it is a research opportunity. And also it's very important to incorporate the patient outcome to highlight the added value of the accurate multimodality breast imaging in the treatment of patients undergoing neoadjuvant therapy. And lastly, as I promised, I would like to shed some light on emerging technologies that we're using now, the contrast-enhanced mammography. It's actually a supplementary tool that I find it very helpful, and it is competing with breast MRI because, as you know, breast MRI is very expensive, and it's not available at universal level, while mammography is, and adding the contrast to it will not be very difficult, especially if people are using it in CT. It's very similar to CT, but it gives us the added value of neovascularity concept that we have in MRI. And I'm sharing 2 cases with you here. This is a 66-year-old woman presenting with right bloody nipple discharge for 2 days and tenderness. She does have heterogeneously dense breast, and we couldn't see anything on mammography, but we did do targeted ultrasound for the right retroareolar region. Sure enough, she does have some dilated ducts. We couldn't tell if there is intraductal lesion, so we decided to add the contrast to the mammography. As you can see here, there's some nodular enhancement, particularly at 9 o'clock in the outer anterior depth of the breast. So now we have kind of a blueprint, and we know where to go when we do the second look ultrasound. So we went back to ultrasound, and sure enough, we went around 9 o'clock, and there is a nodule intraductal that has even internal vascularity confirming that it's solid. We did the biopsy, and it turned out to be a papilloma. A companion case, this is a 52-year-old woman presenting in December, like this month, with a history of bloody nipple discharge for 2 weeks. This is her screening mammogram from almost a year and a half ago, where she had negative, it was completely normal, BI-RADS1, and this is her follow-up diagnostic mammogram. As you can see here, there is interval development of pleomorphic microcalcifications with underlying speculated mass in the right breast. We took her to ultrasound, and sure enough, there is an irregular mass with posterior acoustic shadowing. We did the biopsy. However, we also wanted, if you look back here, there is some nodularity leading to the nipple, and we were worried about multifocal disease. So by doing the contrast enhancement, it's just like similar idea to the MRI. We want to know the extent of the disease. You can see that there is actually nodular enhancement leading all the way to the nipple, which would explain the bloody nipple discharge. So really, we feel like this woman doesn't need the MRI for preoperative evaluation. Contrast enhancement was good enough, and hopefully the surgeons and the oncologists would be comfortable with these imaging modalities to act accordingly. So in summary, the multimodality breast imaging is essential for providing accurate diagnosis for breast cancer. Timely imaging of diagnostic workup is necessary for early detection of breast cancer. Multidisciplinary care is the way to go for optimal management. Neoadjuvant therapy requires accurate staging and follow-up imaging. The new emerging technologies such as contrast-enhanced mammography may have the potential of universal utility to flatten the curve of global burden of breast cancer. Thank you very much for listening, and we're going to go for the next speaker soon.
Thank you, Professor for this excellent to the point presentation. Now I will let the mic to Professor Shenawi. So please, Professor Shenawi, sorry, Professor Ahmed Abdelhadi to introduce Dr. Ahmed Ali. Professor Abdelhadi, please.
I'm glad to introduce my dear colleague, Professor Ahmed Ali, lecturer of clinical oncology, Zagazig University. He will talk with us why neoadjuvant treatment is a standard treatment for HER2 plus or positive early breast cancer. Please, Dr. Ahmed.
Okay, thank you, Dr. Abdelhadi, for your introduction. My task today is to cover a very important topic: why neoadjuvant treatment in a special subtype of breast cancer, which is HER2 positive early breast cancer, not advanced breast cancer. We will focus on early breast cancer, why neoadjuvant is a standard of care now. In order to go for this topic, we need to know what is the goal of neoadjuvant and adjuvant in overall in early breast cancer. The main goal of neoadjuvant is to downstage and shrink the tumor to increase the lumpectomy rates, also to eradicate any undetected cancer cells still in the body, which can be done also by adjuvant chemotherapy. But overall, the goal of early breast cancer treatment is to prevent the cancer from coming back. In other words, the goal is full curing of the patient. So we need to do everything to increase the cure rate of breast cancer. Why we discuss this point? I will start with the last word by Dr. Rola. Cancer or breast cancer worldwide problem. As you see, breast cancer now in 2020 constitute about the second cause of cancer for human worldwide, and the fifth cause of the cancer-related disease after lung, colorectal, stomach, and liver. But when we focus on Egypt, we found that the incidence of breast cancer nearly the same worldwide, by the mortality rate in Egypt near the double the mortality rate worldwide. So I think in Egypt we need to treat patients more intensified treatment enough and increase the screening and prevention of breast cancer. Different treatment goal in early breast cancer and metastatic breast cancer, making an importance of treating early breast cancer aggressively in order to prevent metastatic breast cancer. We treat early breast cancer for cure and prevent the increased incidence of metastatic breast cancer, which is treated with the goal of palliative intent only. And so, as you know, we have multiple subtypes of breast cancer with different biological behavior, with the most aggressive one is two subtypes, HER2-positive disease and the triple-negative disease. And so if we focus on these two subtypes during the treatment with a personalized treatment for two special subtypes, we may increase the cure rate of breast cancer, especially HER2-positive disease. Why HER2-positive disease? Because HER2-positive disease constitute about 20% of total number of breast cancers, affect mainly younger population. These younger populations usually has or have family responsibilities, the age of work. So it has a major problem, not only the disease, but also to the full family. Also, HER2-positive disease is an aggressive behavior, even in a small and node-negative disease need aggressive treatment. So this is the problem of HER2-positive breast cancer, aggressive disease, affect young age female. We need to move to the other thing, is the concept of neoadjuvant. Is the neoadjuvant treatment will improve the survival in the HER2-positive early breast cancer or not? Neoadjuvant breast cancer has a major concern between surgeons, mainly in the past 5 years, based on this long-term outcome meta-analysis that comparing direct adjuvant treatment versus neoadjuvant treatment. And this meta-analysis revealed that there is no difference between neoadjuvant and adjuvant regarding survival and distant recurrences, as we see, but it given a result is that neoadjuvant treatment increased the local recurrence rate versus adjuvant treatment. And so neoadjuvant treatment was not popular among patients at the time due to this result. But when we focus on this meta-analysis, we have many concerns and limitations for this meta-analysis, because this meta-analysis conducted during 1983 and 2002. At this time, there is lack of accuracy and of older imaging techniques to assess the clinical staging of the disease. Also, data about risk factors for local recurrence not present in these trials, like axillary response, like post-operative radiotherapy data, like margin or data about the margin. Also, at this meta-analysis, a major problem that patients that achieve clinical complete response didn't proceed for surgery, and these factors may affect the result of this meta-analysis. And so this statement present in the NCN 2019 that some studies suggest that increased risk of local regional recurrence following the use of pre-operative chemotherapy. These trials analyzed using chemotherapy regimens that are no longer standard now, didn't include targeted therapies, and didn't use modern imaging technique, and some used non-standard local regional management care should be taken to follow the procedure outlined in this meta-analysis. And so National Surgical Adjuvant Breast Project, well-known figure, Dr. Fisher, well-known to Dr. Shinnaw and Dr. Karim, is a big figure for surgery, conducted this trial, P18 trial, which is the first trial designed to test the neoadjuvant chemotherapy. And the primary objective of this trial is to assess if we use neoadjuvant chemotherapy 4 cycles EC before surgery, will increase the lumpectomy rates and didn't affect the survival of the patient versus surgery with adjuvant for EC. And the result was positive. Neoadjuvant 4 cycles AC decreased the incidence of positive lymph nodes and increased the lumpectomy rates with the same survival. What's very important in this trial is this trial gives data about a new endpoint for trials of the neoadjuvant, which is called pathological complete response. Investigators in this trial noticed that there is some patient achieve pathological complete response after 4 cycles of EC, and those patients achieve pathological complete response have a better outcome regarding disease-free survival and overall survival versus patient didn't achieve pathological complete response. And so they proceed for another trial to intensify the neoadjuvant treatment by adding 4 cycles of docetaxel after the 4th cycle of EC in order to increase the number of pathological complete response. this is a primary objective for this study B27, and the result also was positive. There is increased of number of pathological complete response with the adding of docetaxel after 4-cycle AC in the neoadjuvant setting. So the concept of neoadjuvant treatment was correlated with the concept of pathological complete response. So patient achieved pathological complete response in B18 and B27 were compared to patient that didn't achieve pathological complete response, and regarding disease-free survival for those patients and overall survival, and the result was positive. There is improved disease-free survival and overall survival for patient achieved pathological complete response than those didn't achieve pathological complete response. And so a new concern for any trials in the neoadjuvant setting is the definition of pathological complete response, and it is already to be confirmed that it associated with long-term outcome regarding disease-free survival and overall survival. So FDA gave a call for collaboration with the American group and the German group to establish a new trial to confirm the correlation between pathological complete response after neoadjuvant chemotherapy and long-term outcome regarding survival and disease-free survival. This meta-analysis conducted by Patricia Cortazar, including 12 international trials, about 10,000 patients, 61% of them are T2, 46% of them are node-positive disease. This meta-analysis testing the pathological complete response definition and also the association between achievement of pathological complete response and improving survival of patient, and the result was positive. We FDA define or gave a definition for pathological complete response based on Patricia Cortazar meta-analysis, that the patient to be achieve pathological complete response should have no residual invasive disease either in the primary lesion or in the axillary lymph node after surgery. And as we see, there is improved outcome for patient with PCR versus patient no PCR, either in the disease-free survival or overall survival. But this improvement in survival was limited only to the aggressive subgroups, as we tell before, triple negative and HER2 positive disease, and this pathological complete response not associated with improved outcome in luminal breast cancer, only associated in patient with triple negative and HER2 positive breast cancer. So we should focus on neoadjuvant chemotherapy on this two subgroup or subtypes, especially HER2 positive disease. There is association of long-term outcome in patient achieved pathological complete response versus patient didn't achieve pathological complete response. Regarding event-free survival, we have a hazard ratio 0.39. We have significant difference in disease-free survival, either regarding hormonal status, HER2 hormonal positive, HER2 positive, hormonal negative. Irrespective of hormonal status, we have a good outcome if we achieve pathological complete response in the neoadjuvant setting. After Patricia Cortazar meta-analysis, FDA published the benefit of neoadjuvant chemotherapy in 3 directions. The first is tumor downstaging, inoperable, changing tumor inoperable to operable, and increasing the lumpectomy rates, and also changing the concept of axillary lymph node dissection into sentinel lymph node dissection. Also, they reduce the likelihood of post-surgical metastatic disease. And what is very important is neoadjuvant chemotherapy allow us for in vivo tumor sensitivity assessment for selection of the patient and provide prognostic information for planning of adjuvant treatment after surgery. So after this data, now the neoadjuvant chemotherapy, it changed from the previous concept. The previous concept was only for inoperable locally advanced breast cancer in order to enable surgery and was used chemotherapy and endocrine therapy alone. But now the concept is completely different. We used neoadjuvant chemotherapy not only to improve the resection, but also to improve the survival if we achieve pathological complete response in the neoadjuvant setting by not also chemotherapy and endocrine therapy, but also with targeted therapy. So EMA recognized pathological complete response as a surrogate endpoint in early breast cancer, and any drug or any product need approval in the neoadjuvant setting of breast cancer is now tested by the ability of this drug to achieve more pathological complete response than the standard of care. The same thing for NCCN guidelines, and all guidelines now highlighting neoadjuvant treatment in triple negative and HER2 positive disease for patient with a primary lesion more than 2 centimeter and nodal positive disease. And in ESMO 2019, Martin Picard said that neoadjuvant treatment for intermediate high-risk HER2 positive disease, triple negative breast cancer now no longer an option, but an ethical obligation due to the improved survival for patients with achieving pathological complete response. And as we see, high-risk patients for recurrence HER2 positive disease need special attention. Why? Because HER2 positive disease is an aggressive disease. We have about 51% of patients HER2 positive metastatic disease due to failure or relapse from early breast cancer. So if we treat early breast cancer HER2 positive disease adequately, we will reduce this number as low as possible and improving survival of patients. So we now trying to improve the survival of HER2 positive early breast cancer. How? By adding more modern modality, not in the adjuvant setting, but in the neoadjuvant setting. How to improve the pathological complete response, which is a surrogate biomarker for survival in the neoadjuvant setting. How to improve this pathological complete response? The first step was by adding trastuzumab in the neoadjuvant setting in the early breast cancer. This is the NOAA trial adding trastuzumab to the neoadjuvant chemotherapy. If you remember, we have B18 trial using 4EC, then we have B27 trial using 4EC and 4-docetaxel improving pathological complete response. Now we have a new step of adding neoadjuvant Herceptin, but the problem of this trial, we have 11 cycle of neoadjuvant Herceptin for locally advanced breast cancer. And the trial was positive. We have improving the percent of pathological complete response with adding Herceptin versus chemotherapy, doubling the pathological complete response rate, 40% versus 20% for chemotherapy only. But still we have problem. Why? Because we have 42% of relapse during the five-year follow-up of NOAA trial. So we need to do more for those population in order to improving the curve of survival for those population. So we thinking about why some patients are resistant to trastuzumab by what's called dimerization with HER2 in the other hair families. So we prevent dimerization by adding pertuzumab in order to prevent the resistance to Herceptin. And this is tested by NewSphere trial, which leading to approval of adding Perjeta to Herceptin in the neoadjuvant setting. This trial is a phase 2 trial, has 4 arms. The first one is pertuzumab plus trastuzumab plus docetaxel, 4 cycles only. Please focus on this design, 4 cycles only in the neoadjuvant setting. The second arm, Herceptin docetaxel. Third arm without chemotherapy, Perjeta plus Herceptin 4 cycles, or without Herceptin, Perjeta only plus docetaxel 4 cycles. And the result is adding pertuzumab to trastuzumab and the chemotherapy double the pathological complete response rate versus Herceptin only. We have 40% versus 21% pathological complete response. So every step in the neoadjuvant setting increase the pathological complete response that we have mentioned before is associated with longer outcome, either disease-free survival or overall survival. In my opinion, it is very interesting to see 11% of pathological complete response without chemotherapy in this arm, Perjeta plus Herceptin alone. I think those population need further investigation to know who can achieve pathological complete response without chemotherapy. As this arm was designed in the trial actually for safety and testing that what side effect is from chemotherapy or from targeted therapy. But this is the maximum success occur in neoadjuvant setting is adding trastuzumab or pertuzumab to trastuzumab, improving pathological complete response. But NeoSphere trial, as I mentioned, have 4 cycle of chemotherapy plus targeted therapy. So if we increase the cycle of targeted therapy, if we change the type of chemotherapy in the neoadjuvant setting, will improve the pathological complete response or not? This is the idea of Trifina trial. Trifina trial using 6 cycle of treatment before surgery, either first arm pertuzumab plus TCH protocol, which is anthracycline-free protocol, 6 cycle of targeted therapy plus 6 cycle of docetaxel carboplatin. The second is 3 cycle anthracycline FIC, followed by 3 cycle of Perjeta, Herceptin, docetaxel, or using anthracycline plus targeted therapy and docetaxel for 6 cycle. Trifina trial also showing an improvement of pathological complete response. If you remember, NeoSphere trial was 40% pathological complete response. Here with TCH protocol plus pertuzumab, we achieved 63% of pathological complete response. So if you omit anthracycline, you may also achieve a good pathological complete response. But I think this should be subgroup of TOPO2A gene, which benefit more from anthracycline. Also, if you have a cardiac problem or cardiac risk for your patient, you can use TCH without anthracycline plus pertuzumab. Another protocol for neoadjuvant setting was pertuzumab plus trastuzumab in the neoadjuvant setting is Bernice trial, which is the health insurance in Egypt using this protocol. Dose dense AC or FIC followed 4 cycles, followed by pertuzumab plus Herceptin with paclitaxel or docetaxel for 4 cycles. Actually, if we remember NeoSphere trial and the Trifina trial, we complete the trials with the adjuvant setting with Herceptin only disease, with Herceptin only treatment in the adjuvant setting, 1 year. Here in the Bernice trial, we use in the adjuvant setting Perjeta plus Herceptin in whole population. And the problem at this trial is we collect all patients after surgery and putting those population for Perjeta Herceptin for 1 year. Whatever the patient achieved pathological complete response or didn't achieve pathological complete response. Please focus on this point. All trials testing neoadjuvant dual blockade, using dual blockade in the neoadjuvant and in the adjuvant setting, Herceptin only, or dual blockade for the all patient, irrespective of response to neoadjuvant setting, and it was a problem for survival. This is the pathological complete response rate in the 2 arms. It's near 60%, like a Trifina trial. This is a result of the 3 trials of neoadjuvant chemotherapy. And so what's called, I mentioned now is the impact of adjuvant after neoadjuvant treatment with dual blockade. Perjeta in the neoadjuvant guideline recommendation, all guidelines now recommend dual blockade for tumor more than 2 centimeters or node positive disease as Perjeta label. And now pathological complete response. When I tell my patients that you have after neoadjuvant chemotherapy, targeted therapy, you have now pathological complete response, it looks like light at the end of the tunnel for my patient. But still, we have a problem I mentioned before. In NeoSphere trial, we have a very good pathological complete response of 40% to 60% in Trifina and Bernice trial. But still, we have 14% of relapse in the 5-year follow-up. If you remember, NOAA trial using Herceptin only in the neoadjuvant setting, we have 42% of relapse during the first 5 years. But now, if we use dual blockade as NeoSphere trial, this percent decreased to 14%, and we need to decrease this percent in order to improve the survival. And this is what I mentioned before. You must maintain pertuzumab Herceptin in the adjuvant setting for initially node positive patient, HER2 positive disease, early breast cancer. Why? based on data extrapolated from the adjuvant trial, pure adjuvant trial, affinity trial. Affinity trial is an adjuvant, not neoadjuvant trial, phase 3 trial, primary endpoint, invasive disease-free survival, testing adjuvant setting, chemotherapy plus Herceptin alone versus chemotherapy plus Herceptin plus Perjeta. So the results of this trial in the primary analysis was not good, but with further analysis, secondary analysis at 6 years, the absolute benefit increased by 2.8%. This benefit is mainly for node positive subgroup, and there is no benefit for node negative subgroup. And this is the reason that all guidelines now recommend to continue Herceptin Perjeta in patient initially before neoadjuvant chemotherapy targeted therapy was node positive. If the patient at presentation was node positive, you should give dual blockade plus chemotherapy in the neoadjuvant setting. And if the patient achieved pathological complete response, you should proceed for continuation of pertuzumab and trastuzumab in the adjuvant setting. But if the patient initially was node negative, you can de-escalate the adjuvant treatment with Herceptin only for low risk patient. This result was irrespective for hormonal status, either hormonal positive or hormonal negative. Unlike near history, we should also 3 years or 2 years ago consider to continue Herceptin Perjeta in the adjuvant and hormonal negative, but now the benefit is only for nodal positive disease. So I think in the first presentation, if you decide to start with chemotherapy and the target therapy in the neoadjuvant setting, you should, as Dr. Rola said, you should assess the axilla adequately by confirmed pathology to be node positive or node negative disease, because patient with node positive disease, even they achieve complete pathological response, you should give him in the adjuvant setting dual blockade. If the patient is node negative at the presentation, you can de-escalate to trastuzumab only after surgery. Overall survival data of affinity trial still immature. Perjeta in the adjuvant setting, as I said, in all guidelines now given for node positive disease regardless of hormonal status, either hormonal positive or hormonal negative. As I mentioned before also, we have still a % of relapse in the first 5 years of follow-up for patient to receive dual blockade in the neoadjuvant setting. Even with the use of this dual blockade, we have 14% in the Neosphere trial will relapse. In the NOAA trial, if you use Herceptin only, we have about 40% relapse. This is because we didn't personalize treatment according to the response of neoadjuvant chemotherapy. So this is the idea of Catherine trial, that if the patient didn't achieve pathological complete response, what we should do to treat the patient with pathological complete response after surgery, like patient didn't achieve pathological complete response, the answer is actually no. We should personalize treatment. This population different from those population, and we need a new decision at this point. Patient with residual invasive disease have a worse prognosis than those who achieve pathological complete response and require tailored treatment approach. Even this invasive disease is minimal disease, because we have 40 to 70% of patients with residual invasive disease after neoadjuvant treatment, having them at increased risk of disease recurrence. So we need to individualize treatment for those population, not only with using the same regimen in the neoadjuvant setting. So another call from FDA for answer this question and to make a research to this area of unmet need. And so this was the idea of Catherine trial. Catherine trial designed to do more for patients didn't achieve pathological complete response in order to prevent recurrence after neoadjuvant treatment and surgery, including a patient received neoadjuvant treatment, either receiving Herceptin only, about 80% of the patient, or receiving Herceptin plus Perjeta, about 20% of the patient, randomizing, and didn't achieve pathological complete response. then randomizing the patient 1-to-1, either Kadcyla, TDM1 versus Herceptin for 14 cycle, and the primary endpoint invasive disease-free survival was positive. Kadcyla cut the risk of disease recurrence or death in half compared with Herceptin. We have 50% risk reduction regarding invasive disease-free survival. Those populations didn't achieve.
We are running out of time. I'm sorry for interruption. So just can we have 2 or 3 minutes to conclude? Thank you.
I will conclude now. This is the Kadcyla risk reduction 50% in those high risk population, and this is distant recurrence. Also, the benefit present in all subgroups, even in patient with residual disease less than 2 centimeters, and also patient received neoadjuvant Herceptin or neoadjuvant Herceptin plus pertuzumab have the same benefit from adding TDM1 in the adjuvant setting if didn't achieve pathological complete response. And this is the recommendation of all guidelines, and NCCN guidelines listed to add TDM1 if the patient didn't achieve pathological complete response. This is the conclusion diagram. If the patient is presented with node-positive disease, receiving dual blockade 4 to 8 cycles, and then surgery if achieve pathological complete response, low risk, low node negative disease, Herceptin only in the adjuvant, high risk Herceptin plus pertuzumab in the adjuvant. If the patient has a residual disease, you should proceed for TDM1 in the adjuvant. Thank you for your attention.
Thank you, Dr. Ahmed, for your comprehensive presentation, which needs more discussion and more time, but as we have limited time today, so I will let Dr. Shenawi to introduce the next speaker.
Thank you so much. First, before introducing Dr. Karim Fahmy, my very dear friend and colleague, I would like to thank Dr. Professor Gaballa for this comprehensive meeting, which I hope will be repeated several times. And before introducing Karim, I would like to thank Dr. Arola and Dr. Ahmed for their presentations. I would like to stress also on what Dr. Arola was saying about awareness, especially that we have one of the pioneers and my very dear friend, Dr. Nagla Abdelrazik, who's one of the responsible about awareness in Egypt. So I would say, Dr. Gaballa, this could be one of the sessions, and that what's happening in Egypt could be a role model for the whole Middle East and Africa, not only in Egypt, but I think this could be repeated in different countries all over around us. It's my pleasure and honor to introduce one of the pioneer surgeons in Ain Shams University. When you're introducing, he was my resident and colleague, and he's one of the affiliates of Maryland University.
Is my mentor
and
my role model also.
So I would like to introduce Professor Karim Fahmy. Karim is really active not only as a surgeon, but also as a researcher. And this is what's important, and what all the participants, I hope that they will have this in their minds, because without research, you will not achieve anything. So Dr. Karim Fahmy, Associate Professor of Surgery at Ain Shams University, he will be talking to us about surgical challenges in a neoadjuvant chemotherapy. Dr. Karim.
Thank you, Professor Shenawi. Thank you, Professor Gaballa. I would like to thank you for this nice invitation. My talk today about surgical challenges after neoadjuvant chemotherapy. And actually, I'd like to say that breast cancer management has changed dramatically from extensive radical modalities of treatment into more conservative approaches. And our philosophy of management, it changes from one size fits all into more tailored or personalized management. And if you review the history of breast cancer surgery, we'll find that the debate between the Bernard Fisher and the William Halsted proved that they were both wrong and they were both right, because breast cancer is a systemic disease which needs to be locally controlled. And now we are in the era of neoadjuvant systemic treatment, and we all know that the indication of neoadjuvant systemic treatment has expanded to include not only patients with T3 and T4 tumors or node-positive patients, but also patients with HER2-positive or triple-negative patients, even with smaller tumors. And we all see the benefits of neoadjuvant systemic treatment in terms of increasing operability, increasing acceptability, allow us as a surgeon to remove tumors after downsizing it and increase our rate of breast conserving surgery and decrease our rate of mastectomy. Also, we have an oncological benefit in terms of increased overall survival in patients with locally advanced cancer, and enables our dear oncologists to test the response of their chemotherapeutic agents while the tumor is still in the body, which is called in vivo testing. And this will open up the door for a lot for opportunity studies, which include assessment of the response of the tumor to chemotherapeutic agents and enable the oncologists to test these drugs in the adjuvant setting. This is a happy face of neoadjuvant systemic treatment. This lady was suffering from a breast mass at 12 o'clock, about 4 by 6 centimeters. Clipping was done and the patient received the neoadjuvant systemic treatment. The mass showed complete response and wiring was done, and we were able to resect the tumor down to pectoral fascia. Even more, we were able to reduce the size of the breast. We performed what's called inferior pedicle reduction mammoplasty, and everyone was happy. But everything comes with a price. And the price of neoadjuvant systemic treatment is usually and only paid by surgeons, because we know that the response to neoadjuvant systemic treatment may be a favorable response, which is concentric shrinkage in the size of the mass, and sometimes fragmentation happens. And by fragmentation, the tumor here is no longer a continuous structure. It's formed of multiple islands of tumor cells scattered within the original volume of the tumor. Just like in this lady was suffering from a breast mass extending from 2 to 4 o'clock, received the neoadjuvant systemic treatment, and the mass is fragmented. Actually, it took me about 2.5 hours in the operating room to achieve negative margins, which was very difficult. And we all accept as a no tumor or naked margin as a standard surgical margin, but repeated margin involvement during frozen section may put you and your pathologist in a very frustrated condition that you may delay the decision until you reach until the paraffin section comes. And if paraffin section showed there is extensively positive margin more than 4 millimeter, resurgery is a mandate. If it's focally positive less than 4 millimeter, surgery may be equal to radiotherapy. However, resurgery should be done, but if surgery is not feasible, we can do radiotherapy. Another technical difficulty we can have is clip migration. Clip migration we see usually in adjuvant setting. After removal of the tumor, we insert the clip in the tumor bed to facilitate a boost of radiotherapy to the tumor bed. But in the neoadjuvant setting, usually we clip the tumor before the neoadjuvant treatment, because many tumors with aggressive behavior, such as T1 and T2 and the HER2 positive triple negative tumors, usually show very good response to neoadjuvant systemic treatment and usually showing complete response. And this surgery is very boring surgery actually for us as a surgeon, because after the mass disappeared completely, we do what's called clipectomy. And by clipectomy, the clips is inserted into the center of the mass, and during surgery, you put a wire and you drag the wire until to reach the clip. And there is a debate between us as a surgeon whether to see the clip or not to see the clip, because if you open up the tumor down to the clip, it means that you open up the core of the tumor, and if you didn't see the clip, you could be out near or outside, to the right, to the left of the tumor. So to see the clip or to see it is a question, or a very important question. So of course we have disadvantages. Psychologically difficult for female to harbor the tumor in her body for about 6 months. Also, surgical removal is less precise, especially in a smaller tumor with aggressive behavior, such as triple negative or HER2 positive tumor. Also, operating on a primary tumor, which is clearly palpable, is technically much easier. And we all know as a surgeon that axillary clearance on a virgin axilla is much easier than to do axillary dissection in patient received neoadjuvant systemic treatment due to the presence of extensive fibrous tissue. This made a lot of surgeons may consider the need of rethinking the indication of neoadjuvant chemotherapy in selected cases. Actually, I'm not adopting this point of view, but just explaining that there are pros and cons, advantages and disadvantages for neoadjuvant systemic treatment. What about the axilla in the era of neoadjuvant systemic treatment? We all know that axillary dissection passed many phases. It's a dynamic process. Started from complete axillary lymph node dissection down to level 1 to level 2, then sentinel lymph node biopsy, then sound trial, emergence of the rural ultrasound, and determination of axillary status. Now we are talking about omitting sentinel lymph node biopsy. And in the era of neoadjuvant systemic treatment, we do what's called targeted axillary dissection. If the patient has clinically positive lymph node, we clip the lymph node and After surgery, we do sentinel. After chemotherapy, we do sentinel lymph biopsy, remove the cleft and the sentinel lymph node. We are hoping in the future also to omit axillary surgery at all, because the philosophy of breast cancer is always to try to get a less treatment aggressive decisions, because sometimes less is more. This doesn't underestimate from the importance of axillary dissection. Axillary dissection is important in terms of disease control, in terms of as a prognostic factor, but actually the importance of axillary dissection as a prognostic factor is usually declining by time, with the emergence of increasing interest in tumor biology. But what are the limitations of sentinel lymph biopsy in neoadjuvant setting? We have many limitations. First limitation, the high false negative rate. There is a very high false negative rate if you do sentinel lymph biopsy in patients with clinically palpable lymph node, because if the patient has already clinically palpable lymph node, this lymph node could be malignant, could be reactionary. And when you inject the dye into the primary tumor, the dye will not travel to this lymph node because it's a malignant. This means that the lymphatic pathway is obstructed by malignant cells, and the lymph node will not take the dye. Also, in the same situation, if the lymph node is reactionary, the macrophages are saturated and it will not take the dye. So your dye will travel into another lymphatic channel, leading to will go to another lymph node. You will obtain this lymph node and retrieve it, and the center for histopathology, it will be negative. And this is responsible for a very high false negative rate if you apply sentinel lymph biopsy in a clinically palpable lymph node. This is one of the limitations of sentinel lymph node. But is the high false negative rate you do in neoadjuvant setting is reflected in terms of increased incidence of local recurrence? Let's check this. If we go back to B32 trial, we will find that the false negative rate of sentinel lymph biopsy, if you obtain one lymph node, is 18%. This means when you leave 18% of your patients with axillary metastasis behind. And the incidence of local recurrence in the axilla is not 18% of cases, it's only 1.5% of cases. Also in Z11 trial, we all know Z11 trial. Z11 trial recruited a patient with clinically and radiologically negative axilla, T1T tumor, and randomized them into sentinel lymph biopsy versus axillary lymph node dissection. And also 30% of the patients included in the trial, about 300 patients, were left with axillary metastasis behind. And the incidence of local recurrence in axilla didn't exceed 1.5% in cases. Same results obtained from Cenac trial. This trial has the same result of Z11 trial, but actually it included different T population to overcome the weakness in Z11 trial, because Z11 trial included only T1 and T2 tumor only. Again, one of the main difficulties in implementation of sentinel lymph node biopsy in neoadjuvant setting that you cannot apply the rules of Z11 trial. If you have one or two lymph nodes, macrometastasis in two lymph nodes, according to Z11 trial, you should omit axillary dissection. If you have more than two lymph nodes with macrometastasis, you should complete axillary dissection, but you cannot apply this in the neoadjuvant setting. In neoadjuvant setting, if the patient has clinically node positive patient and receive neoadjuvant, and this turned into clinically node negative patient, you have to do, if sentinel biopsy, even if there is only one lymph node positive, you should go for complete axillary dissection. This is one of the trial, in ESMA trials, undergoing trial. Its result may show that even if patient with 3 lymph node macrometastatic, you can omit axillary lymph node dissection. So we have fact, despite leaving metastasis in axilla in 33% of patients, which is considered by many as under staging or under treatment, there is no decrease in survival and no increase in local recurrence. Even more, sentinel lymph biopsy technique itself is not a complication-free procedure, because we still see numbness, tingling, paresthesia, shoulder pain after sentinel lymph node biopsy. And this is why, because I am a surgeon, I can tell you many of surgeons usually do slight axillary dissection during the procedure of sentinel node biopsy, because it's psychologically difficult for any surgeon to stop his mosquito from hunting the axilla when he opens up the axilla. This is the guideline. If the patient has clinically node positive patient receiving neoadjuvant treatment and turn it into still positive axilla after neoadjuvant systemic treatment, axillary lymph node dissection is a gold standard. If the patient clinically node positive turn it into clinically node negative, we can do sentinel lymph node biopsy, but any remaining positivity in the axilla should be treated aggressively by axillary lymph node dissection. And if the patient is initially clinically node negative patient and received neoadjuvant systemic treatment for any reason due to tumor biology, HER2 positive or triple negative, we can do sentinel lymph node biopsy, of course. This is in NCCN guidelines. In conclusion, I will try to say that adjuvant chemotherapy has pros and cons, and do not touch axilla approach is on the horizon. And also there is a paradigm shift in axillary breast cancer treatment from treat all except toward treat none unless. Thank you.
Thank you, Professor Karim, for this elegant presentation. Now, please allow me to receive your questions on the Q&A section, please. Let me start. We received a couple of questions for Professor Rola. Dr. Manar Al-Asawi is asking about during the screening mammography, if you find a microcalcification, in which group of BI-RAD you put the patient for A, B, C?
Thank you for the question. I think the question is whether it's clustered or grouped. So it depends on the type of the microcalcifications, the shape of the microcalcifications, if they are pleomorphic or not. So basically, if they are grouped and they're rounded, probably they are not just, they're not suspicious enough. So it depends on looking at the whole picture of the mammogram. So I would say BI-RAD2. However, the clustered microcalcifications or even grouped microcalcifications that are pleomorphic, they would go up to BI-RAD4. Sometimes if they need the follow-up within 6 months to ensure stability or to get them to evolve into a more benign picture, we give BI-RAD3. So in summary, to answer the question, because it's a little bit vague, if the it depends on the shape and the type of microcalcifications and whether she means group or cluster. I hope that answers your question.
I don't know if Dr. Manar is satisfied with this answer or not. Also, Dr. Manar is asking about a patient during neoadjuvant therapy. Some patients we can find a response to in the primary tumor, almost clinically complete response or radiologically complete response, and still we have a remaining suspicious axilla. This group of patients, how you stage them as a radiologist, and also this question will go to Dr. Ahmed Ali, how to group these patients.
From radiology point of view, as I said, we usually follow the same modality that we detected the abnormality. So let's say, I'm assuming on ultrasound, we saw the primary cancer and the metastatic lymph node. And it's not like it's not an uncommon thing, especially if the lymph node is necrotic. Sometimes necrosis doesn't go away and the lymph node will still look suspicious, even though that the primary tumor has dissolved. And that's where we find breast MRI is very helpful, because the kinetics within the actual tissue can tell us a lot. But again, in terms of, it's always going to be BI-RAD6 regardless, because it's pathology-proven breast cancer, and the management will, appropriate action need to be taken by the surgeon and the oncologist. So again, I hope that answers her question.
Dr. Ahmed Ali, what do you think?
Actually, Ahmed, we should consider the guidelines of follow-up in the neoadjuvant setting. You should differentiate between advanced disease and early disease. Advanced disease need examination, clinical examination, one of the modality of assessment during the neoadjuvant chemotherapy or targeted therapy, and you should assess the patient every cycle. What's interesting to me or important to me is to exclude progression. And you should, if you have a stationary disease, you should continue for the neoadjuvant treatment for the full protocol you use. But what's very important is to exclude progressive disease in order to change the line or to proceed rapidly for surgery.
Professor Lubna Al-Arab is asking about a 28 years old lady with a very strong family history of breast cancer. Professor Ola, which modality you would recommend for screening for these patients, but without any mutational analysis? Professor Lubna is asking only with a very strong family history, and the breast is very dense.
What we do here is actually clinical, like without genetic without genetic assessment, we really don't know what's the best way to take the patient for. So and when she says the breast is very dense, I mean, how would they know that, correct? Like, did she have a mammogram or ultrasound? The best way is actually MRI, and sometimes women start at the age of 25. However, our high-risk screening program in Ontario starts the imaging for both with both mammogram and MRI at the age of 30. So the 28 is just at the cusp. So it depends on the genetic, I would say, the genetic workup of that patient. And I would stick with clinical evaluation at this point and taking the patients for genetics. And based on that, starting at the age of 30, both mammogram and MRI would be the way to go.
Okay, thank you, Professor. Dr. Ahmed Ali, we have a question from Professor Lubna. As we know that in neoadjuvant setting for early breast cancer, we start from the tumor size of 2 centimeters. Professor Lubna is asking if we have any data about neoadjuvant in tumor less than 2 centimeters.
Actually, all trials in the neoadjuvant setting, excluding patient less than 2 centimeters due to the very low incidence of metastatic disease in this stage, as long as axilla is negative. But there is some subgroup in the affinity trial in the adjuvant setting having a patient less than 2 centimeters, showing lack of benefit for those population for dual blockade as long as the axilla is negative.
So you think there is no benefit from neoadjuvant therapy in this group of patients?
As long as axilla is confirmed to be negative.
Yeah, okay. Dr. Karim, you can ask your question to Professor Ola yourself.
Yes, I want to ask about what is the main difference between contrast-enhanced mammography and MRI. I actually asked one of radiologists in our MDT team, and she answered that MRI is characterized by high false positivity because it spotlights on many things in the breast which is not significant, and you have to be able to take MRI-guided biopsy from all these lesions because most of the lesions may be not significant at all. Contrast-enhanced mammography, she said to me that it's preferred over than MRI in such conditions. I want to know what's your opinion.
Okay, that's a very good question, and actually it's a hot topic this year at RSNA, the Radiological Society of North America. There was a debate between 4 prominent breast imagers, what the role of which is better, like contrast-enhanced mammography versus breast MRI. Now we have to know that contrast-enhanced mammography is actually a kind of relatively a new technology compared to breast MRI. Breast MRI remains to be kind of superior given the fact that a lot of research and evidence-based medicine has been done compared to contrast-enhanced mammography. Yet there are a lot of benefits coming along with contrast-enhanced mammography. Number one is the fact that it is available more at universal level. As I said, more than MRI is cheaper. You have the patient in the department, you can have it. Both MRI and contrast enhancement mammography can evaluate at vascular level, but MRI is superior because it can evaluate the kinetics. And as you know, when we make our decisions in terms of the suspicious findings on MRI, it's based both on morphology and the enhancement kinetics, which we don't have that with contrast enhanced mammography. Although, again, it's still a very promising technology, and it's supplementary, and more research needs to be done. Now, in terms of the biopsy, yes, MRI have the advantage that if you see a lesion that's questionable that you cannot see on MRI, you can go back and biopsy it under MRI. But I do think now there is work in progress with some, probably it's still waiting for approval, contrast enhanced mammography guided biopsy, so that if we see a lesion that we cannot find on second look ultrasound, it can still be accessed through contrast enhanced mammography guided biopsy. So I guess it's coming up, and it is a very promising, easy to implement program. We're still in our baby steps at our center, so I really cannot, I'm not the expert on that modality. yet I can see that it's very promising and helpful for our patients.
Thank you. Thank you, Professor.
Professor Ola, Dr. Ahmed, Professor Ahmed Izzat Isa is asking about a question near the question of Professor Karim. He's asking, would you recommend to replace the ordinary mammography or high resolution mammography by contrast enhanced mammography in places with less experts to read the mammography?
Again, I have to say I'm not the expert of contrast enhanced mammography, and I would say my answer to this, no, not yet, because I do feel mammography is the most used modality for screening, and it's available, and even like to increase the confidence level for the extremely dense breast or the heterogeneously dense breast, it has to be in the context of comparing it to the 2D mammography for the radiologist. It's not a CAD. It's not like a helpful or secretary that would help us detect the cancer more. It needs to be done in the context of the 2D mammography as well.
Dr. Ahmed Ali, question from one of the attendees. He's asking you if you have a HER2 positive patients, is a histological type, whether it is ductal or lobular, will differ in the decision of neoadjuvant treatment?
I think it is very low incidence of lobular carcinoma in HER2 positive disease, and this is more for hormonal treatment for hormonal positive disease. But actually, if there is combined pathology in ductal and lobular, I think we go for the more aggressive HER2 positive protocol for those population.
Thank you.
I have a question for Dr. Karim Ahmed. Actually, I see some picture of lumpectomy for tumor near the nipple, and I asked for his experience about the modality of breast conservation for the retroareolar or tumors near the areola, and the limitation of breast conservation for this site of tumors.
Actually, you have a lot of options. In the retroareolar lesions, you can do Grisoti technique, and which is an oncoplastic technique. I prefer it to do in case of retroareolar lesion, which is the most popular technique preferred by surgeons in such situation. And you can do central conductectomy, and we can do, if the mass is not directly below the areola and the nipple, you can take just shaving of the mass from the areola and the nipple and extract the tumor and send it to pathology to see the superficial margin. If superficial margin is involved, you have to remove the nipple and areola. If superficial margin is not involved, you can spare or keep the areola and nipple first. If the margin is involved, you can go for Grisoti technique, which is a very simple technique and popular for most of surgeons.
Thank you.
Let me interfere here, and thank you, Karim. I totally agree with you, but I would like to raise a question, and I don't expect an answer. Are we going to change our techniques during the pandemics? My question is raised, sometimes you are doing some of the conservative surgery and we need to have radiotherapy, but due to the pandemic, as Rola was mentioning, that some people cannot do the screening, sometimes you cannot go and have your radiotherapy. Do we have to do sometimes mastectomy and we avoid conservative because of the pandemic? I think this question needs some answers, and I don't expect. We were trying to do some research in this regards, but as we have multi-centers sitting here, please, Dr. Gaballa, consider this as one of the discussion that we need surgery or treatment in general during pandemics.
Yes, yes. Actually, Professor Shenawi, this is an open question all over the world, not here only. But now with the new modalities of radiotherapy, we have the hypofractionation radiotherapy. The patient instead of going 5 weeks or 6 weeks, now he can go for 3 weeks only for radiotherapy. During the pandemic, it is important to avoid going to the hospital several times. So the radiotherapy over a short period of time, hypofractionation, or yes, if the patient is afraid of being exposed to infection, yes, he can go for surgery, mastectomy, definitely.
Especially Ahmed.
Actually, I would like to thank you, Dr. Shenawi.
Sorry, Ahmed, for interruption. Especially in some countries, we have complete lockdown. not only partial lockdown, but
Yes.
complete lockdown. So it's really a challenge. Back to you, Ahmed.
Dr. Karim, Dr. Lubna, as an Arab professor of oncology at Ain Shams University, is asking you a direct question. Sometimes the oncologist missed to put the clip before the neoadjuvant therapy, and then we surprised with a clinical complete response after neoadjuvant therapy.
Yeah.
So it is a big challenge for you as a surgeon. What you will do?
We do wiring, and we go with the wire until we reach the end of the wire and do blind resection.
Even without seeing the tumor anymore after the neoadjuvant therapy?
Yes.
You go for anatomical resection, you mean?
Yes.
Yes, Ahmed. Sometimes we do quadrantectomy, as Karim was mentioning. So you to be more.
Little bit, you should know the dimensions of the breast tumor initially, and you will be do some sort of generous excision as a safety. But actually, clebectomy itself is a very boring surgery, and I think Dr. Shenawi will agree with this. It's a very sophisticated surgery, especially in small tumors with T1, T2,
Yes.
and receiving adjuvant because they are HER2 positive or triple negative. Usually, this aggressive behavior shows good response to chemotherapy, and the mass usually disappear totally. And you do only clebectomy. A clebectomy is a very boring surgery, and actually you don't feel that you are resecting anything. You just go and you find the clip and you remove block of normal breast tissue. You don't feel safe, and even the pathologist during frozen is not safe also, and very difficult to tedious surgery. And this is one of the challenges we face due to implementation of neoadjuvant chemotherapy for smaller tumors with aggressive behavior. But from oncological point of view, I know that neoadjuvant chemotherapy increases survival in such patients, so I cannot argue with you, but I'm just explaining that we suffer a lot in such conditions. And I think Dr. Shenawi...
Karim is biased, يا أحمد طبعا.
Doctor, this is a...
It gives
you
up
change the... This will take us to the question for Dr. Sorry.
Yes.
Sorry, اتفضل Dr. Karim.
Neoadjuvant chemotherapy.
This will take me to a question to Dr. Rola and Professor Nagla. When to put the clip, before starting the treatment or after achieving part of the response?
As for if the mass is big enough, usually, or even in small masses, so we do put a clip. That's the answer. Like, we'd like to clip the large masses, knowing that the patient will receive, especially younger patients, knowing that they will receive treatment prior to lumpectomy, or even scanning the axilla and finding metastasis there. However, having said that, it's a discussion between us and the oncologist and the surgeons. We do sometimes take the ultrasound guided core biopsy, and if the mass is also large, sometimes we'd say, okay, we don't need to actually put a clip in case the surgery is going to be done before the neoadjuvant. So because it's easy to localize it under ultrasound. But sometimes the oncologist will say, you know what, no, we decided to go ahead and give neoadjuvant. Can you please put the clip in? So again, as I said, it's a multidisciplinary approach. So it depends on how much you know your multidisciplinary team and understanding what type of treatment your team is going to take. So it's not an issue. The issue sometimes is with clipping the lymph nodes, going back and clipping the lymph nodes after taking a biopsy. That would be a challenge, so that you can tell which lymph node actually was biopsied. That would be the challenge.
Dr. Nagla, if you want to...
I have a comment, Dr. Ahmed, for time of clipping. I think if the tumor is large in my clinical practice, I will proceed for neoadjuvant treatment and examine the tumor every cycle. And if I feel the tumor that will disappear, I send the patient to clip the tumor, because I will not expect the direction of response of the tumor. Maybe any direction of response, and the clip will be not in the center of the tumor at surgery.
Actually, also we see, Dr. Ahmed, even with the clipping of the tumor, we see the clip migration during the neoadjuvant setting, and this is also another challenge.
incidence increase if you clip the tumor as early and decrease if you clip the tumor as late as possible.
Professor Shenawi shared with us a paper recently published from the German breast group, GBG group, Sepel about not managing the axilla after the neoadjuvant setting, especially if the axilla was clinically negative before starting the neoadjuvant setting. This, I think, Professor Karim addressed during his nice presentation about we are going to less surgery. Yes. So I think this will be a very nice paper later on. What do you think, Professor Karim?
Of course, it will be very nice. I'm working on a lot of papers. I'm Dr. Shenawi about such topic, and that's all.
Yes, actually, Ahmed, this is a very recent paper. It was just published 1 week ago or something, or 10 days. And it's talking about the sentinel lymph node. And as you are saying, we are moving towards a less surgery. But still, as Karim mentioned, exactly, we as surgeons, while we're doing the axilla, we cannot stop our hands sometimes. Especially that sentinel lymph node in our countries, I'm not talking about Ain Shams, Mansoura, and the big universities. Let's look at other places. And that's why more training and workshops like this are needed. So that's why I'm raising this point.
We have also to differentiate between the setup of sentinel lymph node biopsy in patients with neoadjuvant chemotherapy and patient with early breast cancer. Because, of course, if the patient has neoadjuvant chemotherapy and we perform a sentinel lymph biopsy, we should remove the axilla. Any remaining positivity in the axilla, we should remove the axilla. But in early breast cancer, we should stop according to Z11 trials. And the Ain Shams University Hospital, we are going to do a lot of publications about carbon nanoparticles in sentinel lymph biopsy. In patients with neoadjuvant chemotherapy, we will clip the lymph node with carbon nanoparticles, and the patient will receive neoadjuvant chemotherapy. And then will we do sentinel lymph biopsy and remove the clipped lymph node and the sentinel lymph node.
Yes. I'd like to thank all the faculty for this nice meeting and nice discussion, and I hope we can collaborate in more and more educational sessions and research, inshallah. Professor Shenawi, you are now the vice president of one of the new universities in Egypt. Please try to collaborate with all the universities in Egypt and all the researchers to make a multidisciplinary team in breast cancer and all other disease areas. And thank you all for this very elegant, nice presentation. And I hope we can meet together live, inshallah, after Corona.
Thank you very much.
Thank you, Professor. Thank you. Thank you, Dr. Karim. Thank you. Assalamu alaikum.